So we're going to start with Amin presenting a couple of cases of AF post-Maze procedure.
Great. Thank you, Andrea. Thank you, everybody, for coming and sharing this evening with us. So hopefully we'll just show some cases that highlight some of the challenges, and some of the technical challenges, at least, with these patients. So first patient, 65-year-old gentleman, ischemic cardiomyopathy, lowish EF, bypass graft. Typical kind of patient that we see, recurrent persistent AFib, refractory to both amiodarone and dofetilide, had a cryo-maze at the time of CABG. So they did bypass and at that time did some type of a maze procedure. The biggest issue with him, other than the AFib, is very symptomatic with the AFib, but also has issues with compliance with respect to the OAC. His echo shows a fairly enlarged left atrium. Let's see if that plays. Diameter was greater than 5.5, and so pretty big size atrium there. And so do our procedures on uninterrupted anticoagulation, and just want to show a couple of interesting aspects about the procedure. I think one of the interesting things about him is because it was so twisted and the atrium was fairly enlarged, that the transeptal is very deceiving. You can see it almost looks like you're heading straight backwards right there, but on ice you'll see it tent really nicely. So it's a little bit funny when you look at the where you end up on the fluoro. And I think just a reminder for everybody that fluoro can actually be deceiving when you're trying to do a transeptal and trying to understand where things are. And some people, in particular with very large atria, the needle, look how the needle is pointing almost towards the right atrium. And yet, despite that, that's actually a perfect position where you're tented very well. And that's a great position to cross. So again, showing the power of intracardiac echo and the utility of that to maintain safety, because otherwise you wouldn't necessarily know that in this type of a patient. So first thing, because he's had a prior maze procedure, is we'll do a voltage map and just get a quick idea what's been isolated and what's not been isolated. And very early on, it's very obvious that the left upper pulmonary vein is not isolated. Is this playing? Yeah, hold on. And we can do this fairly quickly with the lasso catheter. So you take the circular mapping catheter and collect points, and you have to make sure you go over the same areas a couple of times to make sure you're in contact. That's occasionally an issue in a large atrium. You may not be in contact, and you might be deceived into thinking some areas are scar when they're not. So really have to make sure that you get contact and look for all the signals. In this case, the left upper was not isolated, and the right lower was not isolated, despite a cryo-maze procedure. And whatever ablation was done was fairly ostial or fairly distal in the vein. They didn't really get much of the antrum or the posterior wall. So that was sort of this guy. You can kind of get an idea of the map as it's being built there. You can use different tools. You can use the pentarray, or you can use the grid, or whatever it is that you like. I think for us, having the circular mapping catheter works very well, and there's no reason to open up other catheters unless you're going to use them. So the strategy in him was ablation of the veins, re-isolation of the veins. Should be right inferior PV and the left upper PV. Ablation of the whole posterior wall, try to obliterate it if we can, and then try to ablate some of the non-pulmonary vein trigger areas that we know about. And so here we go. We're re-isolation of the left upper pulmonary vein, kind of fairly distally in him. Pretty easy to do. And right lower pulmonary vein, fairly proximal to the esophagus. You can sort of see the temperature probe will come down in a second here and get close to where we're ablating. As we monitor the esophagus, you can see it a lot on ice and have to maintain short duration. So if you look at the output, we're at 44 watts. So we're at reasonably high power. You just have to make sure of a couple things. One, you make sure that the contact force is not too high. So when you're going at about 44 watts, we try to stay in a contact force range of 5 to 10 grams. You don't really need 10 to 20 grams in that high power mode. And then also the time that you spend in a location should be modulated if you're going at that high output. So if you want to isolate the coronary sinus, it's really pretty important to try to start doing that from the endocardial side. And again, you can do this at fairly high output, in this case 43 watts. When you're in that area, you need to consider that that's also posterior wall, and even though you're down low near the coronary sinus, you will be close to the esophagus in these types of cases. Okay, so now ablation of the, ablation of the left atrial appendage in this case. So in this case, trying to ablate it during a fib, maintaining contact force, and a pretty high, again, about 43 watts in this case. The final verdict on him was that we did about 50 minutes of RF. Posterior transeptal was fairly misleading, but it worked. Cryo-maze failed to isolate his veins. We targeted the veins, posterior wall, CS, and LA. The LA was ablated but not isolated, in part because of the compliance. So he did pretty well. Actually, he did well for 6 months, where he sent us weekly ECG transmissions, which were all sinus. Did a 7-day Holter, which was good, but then he stopped his anticoagulation and had some shortness of breath. Because he felt well, he stopped his anticoagulation, not under anybody's direction, just kind of stopped it. Felt poorly and had a repeat procedure. So this is just a point I wanted to highlight with this slide here. Let's see if it plays. And maybe I can get the panel to kind of comment a little bit. So one of the struggles with if you're trying to ablate in that appendage area is it's often easy, when you see what's the earliest signal, targeting that area first is often easier, and you can target that, and then that will create some delay in the appendage, and you can keep doing that until you isolate. And so that's one of the tricks, is to cardiovert the patient if you have to, and then do this in sinus. The other thing I wanted to show, and then maybe get some comments before the next case, was ablation of the CS and the epicardium. So this is now within the coronary sinus. And the things you have to be concerned about there is the output's lower, so I'm at 35 watts instead of 45 watts in these. And then you kind of don't want to move the catheter forward as you're ablating. You want to kind of pull back if you can. So you move it forward while you're not ablating, and then pull it back and try to target all of the areas of the CS. When you're close to the os of the CS, you really want to watch for the PR interval. And so having these patients in sinus rhythm as you do it is very useful. And then the last thing to mention, and actually we'll ask maybe Andrea and Luigi about this a little bit, is if you've ablated extensively in somebody, putting your lasso in the left atrial appendage may be useful when you're ablating the coronary sinus. Because as you ablate the coronary sinus, you can isolate the left atrial appendage in people. Yeah. And especially if you've ablated a lot anteriorly and the only remaining connection is posterior, as you ablate inside the coronary sinus, you can isolate the appendage. And you wouldn't know that if you had withdrawn your catheter out. So if I'm ablating in the coronary sinus, I often will keep my lasso up there just to monitor for that. So if you do isolate the appendage, you want to know about it so you can direct the patient in terms of what to do.
And this happens really exclusively when the appendage activation is delayed. So let's say when you're done extensive ablation, the appendage activation is delayed, then you can have, in about 7%, I think we described, right? 7% of the patient have this sort of vein from the coronary sinus, which is not a ligament of Marshall, actually it's usually an anterior branch that connect, they become the last sort of conduit and just by ablating in the CS, that can result in isolation. So you need to record from there, otherwise you might do it inadvertently.
I think the couple of key points in this patient was that if you're trying to ablate the appendage area, ablating in sinus is a little bit easier. Ablation in the coronary sinus we talked about. In this patient, he actually, when we were ablating there, had some tachycardia from there. The big issue in this guy was he was non-compliant with OAC. So if you are going to end up, if you do it by accident or you do it on purpose, ablate the left atrial appendage, this person probably needs to be closed. Because if they stop their OAC, even if they're in sinus rhythm, you have to treat it like a mechanical valve. If they stop their OAC for even a few days, they will have a TIA or a stroke. So this is serious business if you do end up isolating the appendage. Go to, maybe if there's comments, and then maybe we'll go to a second quick case. Yeah.
Any comment?
I maybe missed some of this, but I came in at the point where you're talking about getting into the coronary sinus and taking it quite a ways out.
Yeah.
You know, obviously, if you've
But
got...
before he said you do it endocardially before you go inside, so you do the endocardial first.
Understood. But there's so many times when you try endocardially and you just don't get it, and you have to go epicardially.
Yes.
And I think one of the points that Luigi made earlier today in the AF Summit was that, you know, sometimes you also have to do something with the vein of Marshall, or you have to get out even further, or you have to get into the left atrial appendage and just flat out isolate it. But the question that I had is, you know, at just exactly the point that you showed that slide all the way out, then if there's a vein of Marshall or if there's a left superior vena cava, did you talk about how do you approach it so that in doing that and going out that far in order to get that last little, you know, connection, that you don't nail the left phrenic nerve?
Yeah.
Did you cover that?
No, that's a good point.
point.
In
That's a very
fact,
good
that's a point that you see a lot. You have to consider if you have a persistent left subclavian. So if you have a persistent left subclavian, you're out that far, the phrenic nerve is right there. And so pacing and identifying where the phrenic nerve is pretty critical in those types of patients. So that's actually a good point. The other point is when you're out that far, you know, the impedance on the catheter can be high, so you have to be very cautious about that. And then the type of catheter you use ends up mattering. So the contact force catheters, the stiffer end makes it a little bit harder to get out a little bit. And if you're really desperate, you may have to change catheters in order to make that whole bend up.
Or put in a balloon and blow up in the balloon to open up, you know, prevent the drainage.
Something like that.
Sometimes works. I guess the last question I have is, we always worry a little bit out there, besides the phrenic nerve, we worry a little bit about nailing the circ.
Yes, sir.
Do you really think that that's that big of a deal? You know, have you really had that much of a problem, and do you routinely go ahead and inject? Or you can see it with ice, you know, you can see where the circ is, you can see where it runs. So that would be my last question.
Yeah, I mean, I think if you follow sort of the method of ablating fairly rapidly and moving the catheter, generally speaking, we don't see issues with the circ. We actually don't inject the circ. I don't remember ever having to inject.
We look at the, you know, in the past with even follow-up CT. But if you, so what Amin is saying, beyond moving means that normally, how long do you stay for a lesion in another place? 10 seconds. In the CS, we move every 5 seconds. I actually kind of move the catheter a little bit as I blade it. So you really don't stay in the same spot more than 5 seconds. So you by doing that, and you make sure the catheter is never wedged, by doing that, we really never had an issue with the coronary artery.
The issue of wedging the catheter, in particular some of these branches that come off, you have to be very cautious if you're going to advance. That's why if you're not comfortable advancing, come off RF, advance, and then stop.
Also, you know, it's an anatomical marker, but we recommend doing this CS ablation always with the CS catheter inside. We use the duodeca, and we never push that duodeca above the great cardiac vein. So if you pass that, then the circumflex is an issue. And with the ablation catheter, we try never to pass our mapping catheter. So we stay always below that area. And if you stay below that area, where is the vein of Marshall starts or other connection starts, the possibility of damaging the phrenic nerve is much lower than if you actually push the catheter beyond your mapping catheter more up. At that level, actually, I think that you may be prone to complications.
We're a little bit less concerned about going out, but you clearly are at risk of getting what we refer to as the circumflex wedgie.
Yeah.
And I think we all know that wedgies can be a problem for you.
Yeah.
Typically, to be honest, yes.
So there's an issue with definitions. So the current version of the surgical maze actually does involve a cryo probe into the coronary sinus. And it doesn't sound like that was done in this particular case.
Yes.
And the surgeons who do the cryo, who do mazes of any sort, are limited by the pericardial reflections. So I've had a few of these cases where I've had to do an endocardial ablation after a surgeon has done an epicardial maze.
We had a surgeon that was really, really good at maze and everybody else would fail. This guy would always succeed. And I asked him, I said once, what's the difference? Why do you always succeed? He used cryo, and he said, basically, I cryo the F out of everything. So he was very aggressive with it. And I think kind of you have to be if you're dealing with that substrate of patient, I guess.
Thanks.
Okay, so this is a quick case just to illustrate a couple of points, and then we'll hand it over to Andrea. 71-year-old female, hypertensive, diastolic dysfunction, sinus node dysfunction, pacemaker, persistent AFib, has had several procedures, laser balloons ×2, modified maze with AtriClip closure, 2 LA ablations to follow that, and then been on dronedarone, sotalol, dofetilide, and has some enlargement of the LA. So this is sort of the, maybe I overclicked. But you can sort of see right there where the lasso goes to the appendage area that there's a fair amount of voltage there, and just about everywhere else, or a lot of the atrium is essentially at this point, after multiple ablations, you'd hope that the veins are isolated. And so indeed, in this case, the veins are isolated. Now that's sort of the conundrum, because now you've got somebody who keeps having AFib, but the veins are isolated. So you're really left essentially with the concept that they have to have some triggers that are not coming from the pulmonary veins. So just to show, this is sort of isolation of that stump area. And this is one of the issues. Some surgeons will ablate, then clamp, but that's a minority. The majority will just clamp the left atrial appendage. But you leave this little stump, and that stump can be safely ablated, and it's an area that we find can be causing some AFib. And you can kind of see here as the catheter ablates, you're getting more and more delay on it, so that the signal is later and later into the QRS. And this is not where you want to end. You want to kind of finish this job, because if you don't, then you'll end up with flutters coming from this area. And again, fairly high power on these. I don't remember if this was contact force or not. I think it was, yeah.
It was.
Yeah, but the contact force doesn't have to be super high with this level of power. So you don't have to be at 20 grams. You can be at less than that. As you watch, you can kind of get the sense it's about to isolate there. It's kind of like a pulmonary vein. Once it isolates, the signal disappears. There it goes, disappears. And so the issue is this tissue is difficult to ablate, and the recurrence rates are relatively high. So one procedure doesn't always do it. As you saw with that previous patient, he needed 2 ablations, and even then didn't have an isolation. And then this person also had coronary sinus ablation, similar to the last one, sort of try to isolate that area. So the key points here, isolation of the CS and the LAA, at least now with the current tools, are not possible. And oftentimes, these are the only triggers that we have to address with a redo procedure.
Especially from maze. Surgery.
For this type of maze. So let's see if the panel has any.
Yeah. And the comment is that, we had cases that came to us where they said, the left atrium is silent, but they never really tried to go in the stump of the appendage because they thought, the appendage is closed. But actually the stump, at least, I mean, I guess I cannot say that it's common that the stump is electrically viable because those are the patients we see, so I don't have the whole number.
Do you ever find yourself saying, I just wish I had a paroxysmal from Iowa?
Yeah.
I mean, that's kind of our surgery, that's our practice.
That's your yes. Yeah.
And I just kind of sit there and I just kind of go, I just want a farmer from Iowa.
Luigi, I think you were going to show a couple slides.
Yeah,
before
we mentioned the connection between the CS. There was we just published a paper. There was a debate about the connection between the appendage, if it's ligament or marginal. We actually show in this paper that we did together with Miguel Valderrabano that actually the ligament marshal is not responsible. The ligament marshal is a posterior structure. Actually, when you inject ethanol, the scar that you see is really posterior. It doesn't really affect the appendage. And actually, we use that strategy in patients that clearly had appendage trigger, and we had to bring those people back 100% of them for the appendage isolation. So the ethanol ablation of the ligament marshal didn't do anything for those. Those branch are actually an anterior. So Luigi, just show it.
So we call this patient unusual pattern of isolation of the left atrial appendage. And as Amin said, after extensive ablation, so what we found is that after we were unable to isolate the appendage, and by doing, this is an endocardial CS ablation, you can see that the circular mapping catheter got isolated, and the circular mapping catheter is in the appendage. You can see that burning at this level, the appendage got isolated. So if you're not mapping the appendage, you don't know, but you can isolate the appendage at this level. So this is the number one. The number two is this one. After we were unable to isolate the appendage with the catheter in the left atrium, we went in the CS, and at this level, you can see on the lower left, you can see that there is signal into the appendage, and in the lower right, you can see the appendage is isolated. So you can see that, and we have a signal on the ablation catheter at that level. So we try to understand what's going on here, and we believe that there is another connection in addition to the vein of Marshall, which is this vein, which is we call this the LD band vein from Andrea and me, but it's actually an appendage great cardiac vein. And you can see here that here the vein of Marshall is the lower, and upper there is this vein that connects. The CT scan here is clear. It's an anterior, not posterior vein. So it connects the appendage and the CS. And there's something to understand between these structures that needs to be better understood. And this was not described before. One of the heart reviewers that we had is writing an editorial. I have to say he has been very, very difficult for us, but he was nice enough to show me that he's now looking into the anatomy, Dr. Cabrera, and he found actually in one of his description here, this vein here that connects and different from the vein of Marshall. So we have a connection that is anterior and not posterior between the CS and the appendage, and this is something that we need to think about the interrelationship between coronary sinus and left atrium, which is, I think, an important role, especially in persistent patients. And so we can probably discuss about this.
Okay.